Okay, guys, I know I'm standing between you and coffee, so I'm going to try and smush it a little bit. I have the pleasure of presenting on behalf of Providence Healthcare as well as VCH and my colleagues Pam Papp and Mahoney. And you'll notice that our title, Mega Units and Mega Challenge. So mega units is usually a term that we tend to avoid using in healthcare at all costs. Why? Because when patients find out that they're going to a mega unit, they think, oh my God, I must be a mega patient. What does that mean? And nurses, when they find out they need to go to work on a mega unit, they go, oh my God, I have to work at a mega unit. I must need to be a mega nurse. And nurse managers go, how am I going to be a mega manager on this mega unit? So, but we chose this title purposefully because that is essentially what VCH is embarking on doing and what we have successfully done at PHC. And a mega unit is, if you look at most of the nursing literature, it's a unit that tries to do more than one thing for patients or service more than one need and is generally larger than 30 beds or stations in our case. So the experience at St. Paul's for our in-center unit and the experience at VGH for their in-center unit is fairly different, and we're at different points in our process. So we've actually completed our transition at St. Paul's, and we're about 2.5 years or almost 3 years through the transition, and VCH is just beginning to embark on their transition. So what we had decided to do for the purposes of this presentation is just really focus on the things that we had in common, because we figured if we had things in common in both places, those would likely be the things that would be reproducible at your sites that you could take back with you and hopefully would be useful to you. So essentially, some of the things that we had in common, which is not uncommon in many hospital settings where in-center units are located in BC, is that you're dealing with a really limited geography. Even though both Providence and VGH had gone through huge, expensive renovations, there's just certain walls that you can't take down because they house an HVAC system or an electrical system that is just not movable. So you're stuck within a certain footprint. The other thing that we had both struggled with was really poor patient continuity throughout a patient's journey in their hemodialysis care. One of the big reasons for this, obviously, is because you're really dealing with very diverse patient needs and fluctuating acuity. And being a referral center, we have patients that come from Prince Rupert up to the Yukon to Vancouver to get their transplants or their other healthcare needs, and obviously need dialysis with us while they're there. The communication strategies that were in place prior to changes were outpaced. Hemodialysis units in hospitals tend to grow like patchwork quilts, or cities like London and Paris, where you start with maybe 6 stations and then you kind of need one more, so you pull in another chair, and then that turns into 12 and then 24, and by the time you're finished, you have 46. It's not like a nice city like Surrey that's a grid that has, numbers and is really well planned, although I still always get lost when I go to Surrey, so I'm not sure how that works. And there hasn't been a lot of innovation or change in how dialysis units operate in the past 20 years. So we're dealing with a group of patients, a group of staff at a hospital setting where people really aren't used to having to make big, large-scale changes. And there's a certain amount of, fear, what's going to happen to me, what is this going to look like when it's done, that occurs with that. Briefly, what VGH are planning with their staff and patients is more of a cohort model. So teams of nurses will rotate every 6 weeks and work as a team with a group of patients. At St. Paul's, what we did is we looked at a co-location model for change. So we took patients with like needs and cohorted them. And our motivating factor was really around increasing independence for patients. Because we have a very good home hemo program, which is regional, bless you. And then we had a very heavy, 305 patients at the time, I think, in center. And we thought, how do we get people from here to here? And we thought, well, we'll have to do it very, very slowly. So we were very successful with that, fortunately. The design phase is where VGH is at right now. They're planning on implementing this month and then doing some testing, some PDSA cycles through to December 2016 when their new unit is scheduled to open. For PHC, we're in our sustainment phase now, and we've been sharing our outcomes. We've been incredibly lucky, and we've had great support from our patients, our interprofessional team, and most of all, our nursing staff in helping patients become more independent, which has resulted in fewer hospitalizations and emergency room visits, and allowing patients to better care for their own health and more particularly their access, vascular access. So some learning points and challenges I'd like to say about patient engagement is that there are a lot of organizations out there like Patient Voices Network that will find a patient champion to work with you. But what we found was most meaningful, particularly for hemodialysis patients and the population we care for, is that our care environment is so unique that it doesn't really necessarily help as much to have someone who may have been hospitalized once for a fractured hip to come and help you plan your service. It's really meaningful, and the more learning happens when you actually have a hemodialysis patient who's able to attend and talk about their own experiences. That can be challenging, of course, because who wants to give up a precious non-dialysis day to come and hang out with me and the rest of the team? And of course, the other thing, too, is that we found that when we were able to get 2 patients to come, they would speak out because they kind of felt like they had a buddy, whereas if something happened and one person got sick and only one of the patient advisors was able to come, the other person needed a little bit more of a push to kind of feel comfortable speaking out. The other caution that I'll throw to the wind is that usually with a big change project, there's a couple of early adopters that tend to get on board, and they volunteer for the things like the committees and doing PDSA cycles and helping engage the rest of the staff. And it's very easy for these people to get burnt out if this responsibility isn't shared as the change progresses. Bureaucracy of entities outside hemodialysis unit was the most politically correct way that we could think of to form this statement. And this is everyone from the forms committee and all those sort of hoops you have to jump through. And I learned through going through this big initiative at St. Paul's that we actually have a signage committee. And the signage committee's job is to make sure that the font that you use for any public signs is aesthetically pleasing and that the borders around your signs do not exceed 2 inches, I think. I don't know. I can't remember. But anyway, there's a real committee of real people who do this. And they get really upset when you put up signs and don't tell them. The next quote is from my colleague, Karen Mahoney. And her quote is, "The nurse for the day gets you just that." And I'm going to try and express this sort of in my own words and sort of how I've internalized that. And I think the best way I can put it is that in a large unit with a constant stream of people who are reliant on handy dart, the temptation to get people on dialysis, get their treatment done, get them off, get the next group in, the temptation is very strong. But what I have learned from my colleagues, the hemodialysis nurses at St. Paul's Hospital in the in-center unit, and I see some of you here, what they have taught me is that the hemodialysis nurse is in a beautiful position of privilege to be an advocate, a coach, a teacher, a mentor, a myriad of things, and to really see and help heal that whole person, whatever they come with and whatever their needs may be. So don't get bogged down by the sign committee. Keep your eyes on the prize. And our common next steps are both health authorities or facilities are looking at the Renal Tech Role. We've put a lot of our redesign energy into the nursing role. And so they're sort of the next big group to look at. And we're also looking at, what interprofessional strategies to enhance holistic care should we be putting into place to get things to the next level. We've started things like lower limb screening that we've heard about from Fraser Health. We've started looking at, we have a really good ESAS screening and things like that. And those things are only possible through a truly collaborative interprofessional team, and we're working on strengthening that. We want to promote the role of staff nurses and empower them to participate in rounds, et cetera. And, of course, continue to enhance patient engagement. So if you have any questions, this is who you call.